whole gene that there is a genetic defect to fix the consequences. Next slide. So we didn't have the tools to do this in the past. Now I trained in Philadelphia, and then I went back to Iceland to do a very large-scale genomics project in Iceland. So basically genotyping the entire Icelandic nation. And we have pedigrees in Iceland that go back approximately 55 generations. So we can generate these very big pedigrees, and here's just the representative conditions of autosomal recessive, dominant, X-linked, and mitochondrial. And the next slide shows you one of the, you probably need to press it twice, one of the sort of the bigger pedigrees, but still, this is only going back 11 generations, but we can, on the periphery, you see the filled circles. This is an asthma pedigree where we can link hundreds of patients with asthma and then study flow of generation from one generation to the next to see what do these individuals have in common. So that's what we do with genetic linkage. Next slide. And when the genome was first sequenced, and this took a decade, it costed about $1 billion to do this. And the two major leaders of this, Francis Collins, who is the head of the NIH, and Craig Venter, who ran this very big company. This was sort of an industrial academic race to be the first to sequence the human genome. And when President Clinton announced this remarkable event, which took 10 years to do, he credited both of these parties fairly equally, but one of them looks a lot happier with the credit than the other one, I must say. Next one. And so this led to the HapMap project. You read about the HapMap project. This was basically studying about 60 trios of Caucasians, people from Africa, and people from Asia. And this allowed us to understand the architecture of the genome much better and how different it was between different ethnic groups. Therefore, it's so important that we understand the genome when we analyze data. Next slide. And this led to the so-called HapMap haplotypes of the genome, and then companies like Illumina, as you've heard of, and Affymetrix, they made these chips, this SNP chip that now has about 5 million variants on it. So you can map the entire genome and figure out any location of the genome that associates with a disease. And they can do that by not studying all 3 billion base pairs in the genome, but just studying, and this was actually sufficient to use about 500,000 markers, which was one of the first chips that came out in 2006. And this is when I moved to Philadelphia and we started this project. Next slide. And this is sort of the design of a genome-wide association. Most of these studies are sort of case control when you compare all the cases who have a certain trait with controls who don't have the trait, and you ask for the entire genome, tell me the regions that look different, where there are genetic variants that are either increased or decreased in frequency in the cases compared to the controls. We also, in pediatrics, we can do family-based studies because we can recruit parents. Now, if you're studying diseases like Alzheimer's disease, you can't recruit parents because they have already passed away. But in children, we can. And there you can look at the segregation or transmission of alleles from the parents to the child and see if they're over or underrepresented, because if there is a disease associated with an allele, it's going to be overrepresented across multiple families. Next slide. So the HapMap project was has been very successful in terms of allowing the genome-wide association studies to deliver. And this is just a snapshot to show that there are actually multi-hundred studies now that have been done and have identified genes across over 100 different diseases. And as you can tell by the map, this is all over the genome. And these studies have been replicated all over the world. So it's a very accurate approach to use a genome-wide association to find the location of a gene which has something to do with a disease. But it doesn't tell you which genetic variant is causing it, so therefore you have to do sequencing to do that. Next slide. And this is just to show that there are other types of variants than single nucleotide polymorphisms. There are structural variants, and we call them CNVs, copy number variations. Sometimes you are missing one copy, sometimes you are gaining one copy, and if it happens to be in a gene, it can cause a disease. And the SNP arrays are shown here. This is the normal state of having two copies. You can see you are either homozygous for allele A or allele B, homozygous for allele A, or you are heterozygous for one of each. And the intensity of the SNP data reflects that. And if you are missing one copy, only one copy, you don't have any heterozygosity because you have only one allele state. And the log ratio, the intensity drops. So it's very easy to read it from the platform. Next slide. And we and others, we have published multiple papers where we have found important copy number variants causing autism, causing schizophrenia, causing depression, and many other disorders. Next slide. And sequencing is now sort of, everybody's doing sequencing, and you hear a lot about sequencing because you can now sort of pinpoint the cause of a genetic or of a gene. You can pinpoint the variant in the gene by sequencing the entire genome. So we have built a very sort of powerful pipeline, as we call it, to do whole genome sequencing or whole exome sequencing. Exome means studying all the genes and taking that forward. Next slide. And so when I came to Philadelphia in 2006, we established this sort of genome center with a mission to recruit a large number of children, genotype them and sequence them and find the genetic causes. And we are working on some of the most common problems, ADHD, asthma, autism, schizophrenia, etc. And what is perhaps most interesting sort of with this approach, we have now about 250,000 samples in our biobank from 250,000 individuals. There are now close to 70,000 children we have recruited from CHOP, and they are linked to electronic medical healthcare records that we can update on a regular basis. And we have what's called re-contact with them. They authorize us to invite them back for future studies. So this becomes a very powerful way of studying complex disease. And the electronic records, they go for 12 years. Next slide. And this is the biobank that we had in terms of the samples. This is from a few months ago, and now it's close to 250,000. You can see that we have a lot of healthy kids. We have 68,000 kids who have been recruited and are linked to electronic medical records. And you can see the categories, the autoimmune and inflammatory diseases are the biggest, but it crosses all disease areas, both common and rare. Next one. And this is the robot that stores all the samples. We have a robotic system where we can just go in our computer. This one can store up to about 10 million samples if we have them in plates. And you just order the samples and the robot goes and gets them for you. It takes a few minutes for a 96 sample plate. So it's quite remarkable to see this in action. Next one. Now, I just wanted to sort of emphasize for this subject that we, in our program, all of our recruitment is handled by nurses who lead that effort. All the in-hospital recruitments are all handled by nurses, and most of the nurses come from the School of Nursing at Penn, which is probably one of the best nursing schools in the world, ranks really high, and they have their own curriculum in parallel with the medical school as you have here, and obviously it's a very sophisticated institution. But we have key leaders in our recruitment process, in our IRB process, in returning results to individuals. Nurses and counselors, they handle all of these activities. So this is really could not be done without. And next slide. And now I wanted to tell you about a couple of projects, and I was going to sort of cut my talk a little short because we are a little bit over time. Neuroblastoma is the most common of solid tumors in children, and I'm sure you have all encountered children who have neuroblastoma. This is the most lethal of all pediatric cancers, and most of the time when you diagnose neuroblastoma, it's too late because it's an advanced stage, and these children, they respond poorly, and that's why it's the most lethal condition. Next slide. One of the first study that we did, and because I was working with all this family-based material in Iceland when I came to Philadelphia, I started by doing a linkage project in familial forms of neuroblastoma, which is only like 1% of neuroblastoma. And this study was just, we genotyped everybody with about 600,000 markers, and then we just looked at 10,000 markers across the genome to get linkage. Now, sporadic cases of neuroblastoma are well known to be associated with some copy number variation in C, NIC, and other regions that are associated with risk, but no one knows the underlying cause. So next slide. So we did linkage, and we found actually this sort of big region which was harboring a number of genes, probably about 60 or 70 genes. But interestingly, there was a gene which is an oncogene at the end of it, and there was another kinase gene which is called ALK, or anaplastic lymphoma kinase, at the other end of the peak. So the peak, linkage peak, sort of goes like this, so MYC is here and ALK is here. Next slide. And then when we had sequenced through MYC and failed to find any causes, we subsequently sequenced through this ALK gene. And we found activating mutations that change this tyrosine kinase enzyme, which should be an on and off, to be constitutively expressed all the time. It drives proliferation, and it drives the cancer in the sympathetic nerves of these children. So if you have this mutation, you just have an ongoing stimulation to drive the cancer, and you don't respond well to any therapy. Next slide. And all the families, we had about 12 multiplex families, all but one had this mutation. There were different mutations, but they all did the same. Next slide. And interestingly, when we looked at the tumor in sporadic cases, 15% today, it was about 12% at the time, 15% of children with sporadic neuroblastoma, they have somatic mutations. Not the germline, not what you are born with, but the sympathetic nerves had a mutation that caused the tumor, and it was the exact same tumor. Next slide. And what we learned was that this kinase was being worked on as a sort of drug target for Pfizer, which is one of the big drug companies in the world, as you know. But they were studying patients with lung cancer. And they had seen that a very small number of patients with lung cancer was responding to the medication, like 2 or 3% of patients with lung cancer. And they had no idea why. And then when we found these mutations, of course it was, aha, maybe these patients have mutations. So they took our mutations, sequenced them, and found out that yes, only the patients who responded to this were patients who had mutations. Next slide. And so what we did was actually to get the drug from Pfizer, and we treated, and we published this now about a year ago, the first trial of 23 kids with neuroblastoma and positive mutations. And the tumor melted away, disappeared in these kids. And Pfizer subsequently learned that not only lung cancer, but lymphoma, colon cancer, and multiple other cancers had a subset of patients with this mutation, and those patients all responded to therapy. So this is sort of like a molecular phenotyping, because you don't care what the cancer is called. If you have this mutation, you're going to get cancer, and if you get cancer, you're going to respond to this therapy. So this is sort of going from a very rare familial form of neuroblastoma, present in 1% of neuroblastoma, and neuroblastoma is only like 1 in 5,000. It's really, really rare. Now to a big therapeutic program treating subset of patients with all cancers. So it's quite a remarkable sort of involvement. Next slide. So I was going to talk about autism for like 4 minutes, but
you want to have 4 minutes?
am I 4 minutes?
You like
Okay.
to have 4 minutes? Because
4 minutes.
because
Autism is, so you know the phenotypic spectrum of autism, which is obviously very difficult, the repetitive behavior, the social lack of skills, and their sort of isolation and verbal difficulties. And then multiple other sort of comorbidities that go along with autism, and this is sort of trying to show that with the Venn diagram here. Next slide. So autism is inherited in most of the cases in a very complex way, but there are a subset of patients who are sort of familiar. And next slide. And these are the syndromes, so-called syndromes of autism. And I specifically want to point out the tuberous sclerosis and the Fragile X, which are sort of the most common. Fragile X is actually the most common syndrome of autism, because there are now therapies that we are developing that works actually on these subtypes, and we are heading with this into clinical trials, but I'm going to talk about that part of it in my next talk with the future of genome medicine. Next slide. So what I wanted to just in 2 minutes touch base on is that we found this common region in 2009. So this was the first time that Genomite Association found a genomic region that sort of replicated across multiple individuals. And there was no gene in the region, but there were cadherin genes. These are neuronal cell adhesion molecules that are very important for connection between nerves. Next slide. And we sequenced the whole region, and we found a whole lot of mutations in there. And next slide. But when we looked at RNA in the region, and we did this, and colleagues of ours in San Diego, we found that there was a non-coding RNA sitting right where the signal was. And this non-coding RNA had a sequence which matched the sequence on a gene on the X chromosome. It is called MSN, and codes for a protein called myosin. And myosin is a critical protein in axonal nerve growth and development. Next slide. And this particular antisense, which binds to the protein on the X chromosome and blocks the transcription of the myosin, could explain why autism is so much more common in boys, because this is on the X chromosome where women have 2 copies and boys have only 1 copy. But it was expressed 12 times more commonly in the brains of patients with autism. And this non-coding RNA, as I said, binds to this MSN gene and blocks it. Next slide. So here is basically another opportunity, because this is a common variant, to intervene. So we are now doing animal studies to figure out how can we get rid of this non-coding RNA, because this is a reminiscent sort of gene. This is an old gene that the body is trying to get rid of, and therefore it's not coding for anything. But it just functions now to inhibit the X chromosome gene, which is involved in the development of the nerves. So that's why it's so important to understand this, and now with intervention in animals, we hope to figure how to be able to cure a subset of autism. Next slide. And I was just going to stop here and take questions if you have any. Otherwise, we will take questions at the end. Thank you very much.
I'm sure you have good questions, very important topic. We leave it to the end, بس هلا بنطلب من زملائنا التانيين to make it a little shorter, please. معلش يعني عشان احنا يعني الناس عم نحكم وانتم منا وفينا.
Our second presenter is Dr. Manar Nabilsi. Dr. Manar from Jordan University. She's a special cancer. She's the adult nursing department and adult nursing department. She is the vice dean of the head the head of Department of Graduate Studies in the faculty. She graduated from, she got her PhD at 2005 from Paris University at UK. Her presentation is the title of the Clinical Practice Experience of Nursing Students in Jordan. Please, Dr. Abnal, stick with the 15 minutes time. Thank you.
Good morning everyone. صباح الخير. مساء مساء الخير واهلا وسهلا فيكم. طبعا انا اسمحوا لي ابدا اني اشكر جمعيه البحث العلمي في الاردن ممثله طبعا بزميلتنا استاذ دكتوره وسيله بيترو اللي اعطونا هاي الفرصه نعمل برزنتيشن لبعض ابحاثنا. Today I'm going to talk about the experience of Jordanian nursing students in their clinical experience. I'm sure يعني everyone of us will relate to this topic because we are all nurses and we are all teachers and we are really, it's very important for us that we work with the students so we give them the experience, the knowledge so they can practice as nurses. So this research study was carried out by me and my colleagues Ms. Arwa Zamot, Lina Wardam and Dr. Fathiya. So to start with introduction, talking about nursing education, as you know all, nursing education is integration of theoretical and practice learning experiences, which usually aims to provide the students, nurses with the knowledge, skills and attitudes required for their future professional roles. Next please, as nurses of course. So, as you all know, clinical training really is considered a complex process. Although it's sometimes they feel it's easy to teach or to train nursing students, but actually it's really a complex process, which mainly it's a vital component of the nursing curriculum. And through clinical training, what is expected of teachers, clinical preceptors, instructors, to facilitate the students' application of the theoretical knowledge they had in the classroom into clinical practice settings. So, through clinical training, usually nurses and teachers and instructors, they do their best to enable the learners to integrate their knowledge, their learning, psychomotor skills that is associated with providing nursing care and meeting the healthcare needs of the person, the family, and the community as well. And also it helps them to socialize into the nursing profession. So as you all know, the clinical settings, they vary. We have the hospitals, outpatient clinics, health centers, hospice units, and other healthcare settings where each setting has its own learning objectives for each student. So, since the quality of students' clinical experience is an important determinant of the quality of nursing education, so it's therefore important to ensure that students receive the best quality of clinical teaching and training during the period that they spend in the clinical areas. So, to enhance the students' learning, there is a need really to identify the strengths and then and the weaknesses as well of the clinical training. So one way to do that, we thought of how can we come to a conclusion where how can we really evaluate how the clinical experience of the students affect them and affect their knowledge and psychomotor skills. So we thought that it's one way to do that is mainly through allowing the students themselves to reflect on their clinical experiences and talk about it freely from their own perspective. So the purpose of our study was to explore the experience of nursing students in their clinical training at the baccalaureate nursing program in Jordan. The methodology, the design we chose that because we wanted the students to explore and express their experiences, so we chose to use the phenomenological qualitative method to reveal the meaning of the clinical training by the students. So to do so, we had a sample, a purposive sample, a convenient sample of 30 students who were selected from Faculty of Nursing, and in different years of their education, so we'll have the general picture of it, and mainly the students who were volunteered to enroll in the research. So the data collection, we had 2 focus groups. Each focus group was around 15 students. Altogether were 30 students, and the focus group lasted for around 2 hours, where the students were exploring their experiences. We used semi-structured interviews to allow the students to explore their learning experience. In the data analysis, we used the interpretive approach by Gadamer to analyze the data, and then we did a thematic analysis to extract the themes. The interpreted themes, of course, they were re-examined, they were validated, they were reformulated according to the participants' comments. Of course, we had the ethical approval. I don't want to go on, just... Okay. So, the result analysis of the 2 focus groups revealed 5 themes that represent the experiences of our nursing students. We'll start with the first theme. The first theme was a supportive clinical environment facilitate effective learning. Second theme, motivation and goal-directed practice are cornerstones in fulfilling the intended learning outcomes of clinical training. The third theme was instructors and nurses are our role models. Fourth theme, incongruence of expectations, and this was interesting, between students, preceptors, instructors, and nursing staff. Reality is very different from what is expected or taught in theory or lab. And for the discussion, of course, mainly the finding agree with the literature and disagree with some of the literature. Like mainly, they all agree that providing supportive clinical environment would optimize teaching and learning process, influence student satisfaction with their training, play an important role in the development of students' competency, confidence, organizational skills, preparedness for practice, and career intentions. So, a nurturing and supportive environment can be created when the divergent but compatible organizational aims of the service and educational sectors are merged in a climate that encourages collaborative learning, trust, mutual respect. Okay? However, unfortunately, in our study, it was not obvious that this is, there is a deficit in this regard. Next. So, establishing a good collaboration between nurse educators and clinical setting staff in developing clinical education philosophies and identifying individual students' learning opportunity is expected to enhance the clinical training and nursing students' ability to transfer theory into practice. So preceptors in the current study, they were perceived by students as not being able to provide effective learning, which is an unfortunate findings. Accordingly, the literature supports the notion that preceptors need to work with students to create a positive learning environment in order to optimize their learning experiences. Several factors were found in the study and discussed also in the literature that influenced the students' clinical experience. Some of them were the individual learning characteristics and style, and I think we need to really understand this aspect from the student's point of view. Clinical setting circumstances, because we have a variety of clinical settings, preference of teaching and learning by the students and the instructors and preceptors as well. So during the clinical placement, students, they were expressing about what emotions they had. So most of them, they really experienced period of feeling of despair, frustration, and anxiety, uncertainty, lack of motivation, lack clarity and understanding regarding their role, and expectations as students and that of the preceptors or instructors in the achievement of clinical training learning outcomes. Preceptors and instructors really need to, we identify that they need to encourage students to be proactive in reaching their learning goals, even in a busy and understaffed work, because most of the time they had to work as staff nurses rather than achieving their own learning goals, and this causes conflict and frustration among them. So a key issue in this situation is setting realistic expectations of both preceptors and students that is important for students to maintain their motivation and the sense of achievement throughout their clinical experience. The other aspect that they were discussing about is the characteristics of the teacher. The characteristics of the teachers, preceptors, and instructors as being the student's role model played a major and important part in their learning process. And that's why really we need to encourage preceptors, nurses, instructors to be really a good role model for our students in the clinical settings. So, some of the effective clinical teaching behaviors that have been discussed to facilitate students learning clinical settings were, for instance, conveying a positive, enthusiastic attitudes about teaching and learning, giving immediate feedback to students about their work, adding humor to clinical. We are very always tough with our students, and they were discussing that we need to add some humor to our clinical teaching, support, motivation, approachability, consistency in evaluation. We had really, most of the students were arguing that we are not getting a fair evaluation. So consistency is very important, being organized, maintain effective communication skills. We have really problem with communication also. So in this study revealed several barriers facing the students' clinical training that's highly discussed also in the literature. That students often find it difficult to learn during practice placement due to too many students allocated to an area at any one time, and difficulty in transferring theory into practical situation. So really also we found that really there is a difference between the clinical learning environments where the students from the lab or the theory into the complex social context, so they have some conflict in achieving their goals. So this diversity resulted in congruity between the students' ideal expectations and the real clinical environment that contribute to theory-practice gap. So a supportive clinical training environment is most influential in the development of nursing skills, knowledge, and professional socialization, providing students with unique learning opportunities in which theory and skills are implemented in the real situation. Next, please. As a conclusion and recommendations, both the clinical educational environment and the characteristics of the clinical instructors found to be playing a major role in empowering students' learning, bridging the theory-practice gap, enhances the student's sense of responsibility, provides them with opportunities to demonstrate nursing competencies. And as recommendations, we recommend that preparing good instructors, preceptors, and nurses to be positive role models for students is crucial in nursing education. Appropriate selection of the clinical placement is recommended to ensure quality clinical education. And finally, our recommendation is that we need further studies to explore the experience of clinical instructors to identify the perception of educators regarding clinical nursing education to provide evidence to enhance positive, effective clinical training, and we are working on this research. Thank you very much.
Thank you very much for Dr. Narnabisi, and I'm sure that academics will get benefits from these results. Thank you. Our next presenter is Dr. Abdullah Al-Khawali. He's Assistant Professor at Community Health and Pediatric Health. He has his PhD from Jordan University. He is now acting as a Vice Dean of Nursing Faculty in Jerash University. Welcome, Dr. Abdullah.
السلام عليكم. يعطيكم الصحة. نشكر القائمين على هذه الفرصة في هذا المؤتمر. نشكر الدكتور. شكرا.
May we have your attention, please? Presenter will start.
Assalamu alaikum.
Thank you.
My paper was conducted with collaboration with my advisors, Dr. Margo and Dr. Wasila and Dr. Madi Jagbir, under the title of Factor Associated with Primary Healthcare Service Utilization by All Ages in the Urban Governorate north of Jordan. Next. As we know from figures recently, there is high increase in the percentage of the old ages in the community. And this can have negative consequences which lead to a lot of chronic illnesses, disabilities, and physical disability and social needs, psychosocial needs. Please. Okay. As we know, primary health care is very important to the health of the population in terms of can offer or provide us with more effective health services and fair and equity health services for population in the community. In figures, we can see that according to the world population is aging. At the present, there is about 600 millions that age 60 and more globally. We can, to 4 point, we can see that by the year of 2050, the percentage of old persons in our country is expected to reach 19% of the total population. Next. What about Jordan? We see from the table that in Jordan in 1950, it was 4.8% of old ages in the population. Then the percentage is decreased until 1995, which reached 2.5. Then after that, in 2005, it started to increase to 3.5. Then in 2010, it reached 3.7 and expected to reach in 2050 13.8 from the total population. Next. Next. The healthcare of the old presents significant unmet needs for two reasons. First one, it is not mentioned specifically the old ages in the Millennium Development Goals. The second one is inadequately understood in several parts of the world regarding utilization, specifically for the old ages. Problem statement, there is a gap in the literature regarding the old ages and there is a gap regarding health and social needs of the older adult. A comparative literature review revealed a gap in the research regarding health research regarding factors associated with primary health care services in Jordan regarding old ages. Next, please. This study has a relevant result. The result of this study will have a relevant for research, practice, and health policy and healthcare system. Next. The purpose of my study was to examine patterns and factors that associated with primary health care utilization among old ages in the urban governorate. Old ages means 50 years old and more. Research questions, 3 research questions. First research, what are the pattern of primary health care service utilization? The second, what are the predisposing, enabling, and needs factors associated with primary care service utilization among old ages? And the third question is, what factor predict the probability of using or non-using primary health care service by old ages? Next. Literature. If we want to define utilization specifically with quotation, it is the process of seeking professional health care and submitting oneself to the application of regular health services with the purpose to prevent and treat health problems, according to Chambers. Pattern and factor associated with old ages utilization in terms of literature. There is a lot of literature. For example, in 2009, 2010, 2004. Next. Stop here. For example, 2006 in Spain conducting a study, one of them regarding nursing services. For example, they found that nursing staff visits consist about 80.4%. Next. factors associated with alternative service utilization. There is a lot of variety of study that conducted this or covered these topics. Some of them use explicitly Anderson model of primary healthcare service utilization. Next. Next. In Arab country, there is scarcity in studies that examine or cover this subject. For example, in Gaza Strip, in Palestine, in 2008, they found that interview patient of about 64.7 reported high use of primary healthcare service use. Also, they found that predisposing factors such as age, also enabling factors such as income and needs factors such as poor rated health is all of them are factors that predict or associated with the use of healthcare services. In Jordan, there is scarcity in the resources in research regarding such issue, which is utilization. However, some researchers cover this issue in some study. For example, general health status of the population was conducted, a survey conducted in 2000 by Ministry of Health. Also, health status and utilization of health services was studied by Taani. Also, Abu Rub in 2009 studied satisfaction with healthcare services. And Dr. Bitro in 2001 studied utilization of specialty health services such as maternity services. Simply, we depend on which is called Anderson model of healthcare behavioral utilization, the Anderson behavioral model of healthcare services use. This model consists of 4 developmental stage and 5th emerging phase. Next. 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 This is the Anderson model with the 5th emerging phase. Next. For our study, there is a group of factors that we study it or examine it in our study. Predisposing factor, enabling factor, needs factor, their effect on the, okay, stop. This table reflects or this table summarizes the using of Anderson model in out of study. For example, different years, different authors, different countries, different populations, and different age group. Next. Methodology. We use cross-sectional study design. Next. The setting was, we choose our sample from catchment area associated with 3 comprehensive primary healthcare systems in the northern part of Jordan in Erbil. Next. This is the area. Al-Nuaimi area, Al-Mazar, and Al-Ramtha. We choose our sample in 3 stages. First stage, we selected 3 comprehensive primary healthcare systems out of 10. Next stage, we select the household from the area surrounding or within the scope of services of these 3 comprehensive healthcare systems. Then we choose from the household within these areas. This is the weighting sample for each area, weighting numbers of household, the number of participants from each area, Al-Ramtha, Al-Nuaima, and Al-Mazar. Instrument, we use socio-demographical tools. The second tool is cognitive assessment questionnaire. Also, we use SF12 V2, which is called 12-item short form health survey version 2. This is reflect the questionnaire, cognitive assessment tool. Next. And this is the SF12 V2 version 2, which is assess the quality of life in terms of physical and psychological component for 4 weeks only, period of 4 weeks. Ethical consideration, we take permission to conducting the study, and we take permission from the tool developers. Next. Data collection procedure, data were collected by the researcher itself and with assistance of a female. Also, we started the interview by collecting data regarding social demographical data. Then we assess cognitive impairment. At the end of the interview, we assess the utilization pattern and the need factors. Statistical analysis, descriptive correlation, then. Okay, next. And logistic regression, and we use special software to calculate the scores of the SF12 V2. Yes, the result of the tool. Yes. Our study, well, now we come to result. As we can see, descriptive result. This is the result descriptive of the study, the characteristic of the study. Next. This is reflect the pattern of the utilization of primary healthcare services. We can see we differentiate between medical services and nursing services. We can notice that nursing services in the 3 period, 1 month, 6 months, 12 months, less than 50. Next. Okay. This table reflect or describe the factor associated with primary healthcare services in the 1 month, 6 month, and 12 month. We notice that the age associated with utilization at 6 months and 12 months. For example, the enabling factor, none of them associated with utilization. Next. These three tables reflect the result of logistic regression, and we found only chronic illness is the predictor of the utilization of primary healthcare services by old ages, 50 years old and more. Next. Discussion and conclusion. Utilization, and as we see from the tables in the past 1 month, we see medical services is for nursing less than 50%. For medical doctor, it was at 1 month less than 50, which can be explained that older ages is not usually use primary healthcare services per 1 month, mainly by 2 months or 3 months for taking their medication. Next. The factor associated with primary healthcare services, age, education, employment. For example, age, as we can see in the table, it was inconsistent. The first month it was not associated, however, in the second 6 and 12 months it was associated with utilization. Next. Chronic illnesses, as we said, it was associated with the utilization of primary healthcare services in the 1 and 6 and 12 months. Cognitive impairment was not an agreement, it was not associated with primary healthcare service utilization. It may be explained that only 3.2% of the cognitive impairment in our sample was a percentage of cognitive impairment, only 3.2. Factors, next.
It's just 1 minute to go.
Okay. As we see in the table, we found that only chronic illness was the predictor of primary care service utilization. Next. Limitation. One of the major limitations of our study is which is called recall bias. We try to minimize recall bias by using 3-period time to assess utilization, 1 month, 6 months, and 12 months. Also, we measure utilization binary dichotomous, used, not used. This is 2 main methods which we use to minimize the recalling bias in this study. Thanks for your listening.